start with the session number 4, that is on statistics and how how it affects. Statistics is a numbers game, and that is why most of the doctors don't want to enter into that. But using evidence-based methodology, it becomes easier. Now, research basically has divided into 3 parts. What is done, what is happening in the past, and you are looking into it in the present form. What is happening in the present, and then you are looking at what is going to happen in the future. And the third part is what is in the present, and you are looking also in the present also. So these 3 methods you divide all the research which is there. And what do you see is the risk factors, the frequency which was, and what prognosis or what disease it takes place. Now, if you want to go into the past and see, then you have the case control and the retrospective cohort study, which will look at the risk factors and see if the disease has progressed or not. And that is how causality or any event which is there, precipitating of the event which is there, that is studied on a retrospective method. On the other hand, if you want to see what is at present, the present risk factor, and whether they ultimately convert into disease processes, either by intervention or otherwise, then you have to go for inception cohort study. If you want to look at the treatment and then what are the effect, efficacy and efficiency, then you have to go for randomized control trial. And in the present, if you want to find out frequencies, then the cross-sectional study, observational studies, surveys, which are the main reason by which we could do that, those are done in the present and also evaluated also in the present assessment. In the past, what has been done and that evaluation is taken place from records which are available in an institute or in any place. So it is a record-based evaluation. You do not get a good control group in that particular place, and that is why they are evidence-wise they are little less. With randomized control trial, inception cohort, both the places you are getting a control group, and that is why these are better. Cross-section and observation are just basically observation. It does not give you the treatment. So let us see how evidence-based affects diagnostics in our day-to-day. Normally, whenever we use evidence, we are looking into a population. So what are the results, mean and average on a population, and how it can be utilized for that individual patient who is right in front of you. That is what evidence-based teaches you. To from the population, go and apply to the individual concerned. And that phase which is there should be, if it is done by proper evidence-based method, that is possible. So diagnostic test efficacy is dependent on, say you have a new test you want to find out, you test it against a reference test which is already existing. And then you look at the value of the test in terms of sensitivity and specificity. Sensitivity is that where you get the positive result in a patient who already has the disease. Specificity is you get a negative result of a test once when the patient does not have them. There are other components called as spin in and spin out. Spin in is high when the test is has high specificity, then the positive result in favor of the diagnosis. When the test has high sensitivity, a negative result will always favor that the patient does not have the disease. This is the importance of considering the spin and spin out, which is based on sensitivity and specificity of a given test, and depending on that you will get the probability. So when a sign or symptoms is extremely high, say 95%, a positive result tends to rule in favor of the diagnosis. For example, if you have a 5-point questionnaire to be given to a patient and 3 out of the 4 are positive results, then the diagnosis of the disease is 90% sure for those kind of patients. So if the patient answers more than 3 or 4 questions in the positively, then the patient probably has the diagnosis. This gives you the probability that a patient has the disease, and that is how research methodology is used. On the other hand, sign out when a sign, test or a symptom has a high sensitivity, a negative result rules out the diagnosis altogether. For example, loss of attachment is invariably there in 100 percent of the periodontist patient. So if there is no loss of attachment in a patient, he doesn't have that disease. Normally, whenever you do the diagnosis, you should know this, how to put this into a 2x2 table. The index test which is there is positive and negative results on one side, and on the other side it is a disease present or not. And then sensitivity and specificity is calculated according to this formula which is there. These are very simple things. Only thing you have to understand, forget the statistical measuring part or calculating part. What you need to do is you should know how to make a 2x2 table, and that 90% of your work is over once you do that. Now, knowing that the sensitivity and specificity is very high in this, in the previous example which you took, which means the test is very good. But then the question arises, does the patient really have the disease? Because test may be correct. So that is why the next step which you should see after sensitivity and specificity is the likelihood ratio. The likelihood of a given test result being expected in a patient with the disorder compared to the negative results and the no disorder in that particular. That tells you positive likelihood ratio and negative positive. Again, the formula is given and you can easily calculate in those patients. This is how evidence-based works. It's on likelihood ratio. But then the third question comes. Can it have occurred by chance? Because sensitivity is good, the test is good, specificity is good, likelihood ratio is high, so probably the disease is present, or if it is too low, likelihood not present. But can it be occurred by chance? So for that you need p-value. P-value means that if you test 100 times, you may not get a correct result in 5 times, but in 95% of the time you will get it, and that is denoted as 0.05. So that is the statistical convenience which is there. There is no real basis for that, but statisticians consider that 5% error is can be allowed, and that is why this methodology of taking a p-value was started in the first place, and that is why it is continuing today. But this does not tell you the significance. It tells you only statistically whether it is significant, but it does not mean that it is clinically significant. Clinical significance and statistical significance are two different things, and we should not mix up. That is why p-value should be mentioned only in numbers. It should not be as a significance or non-significant level. Now, p-value gives you the reason why we don't call it significant or insignificant is because p-value changes with the sample size. Larger the sample size, the better is the probability that the bias is not there. So, that is what the value of p-value. But then again, the question comes, even after doing the presentation, are we confident? But we are not, because p-value is just one thing. So nowadays we do what is called as confidence interval. That is 95% confidence interval. It gives you a range. Okay, the likelihood that a 95% range, 95% possibility is falling into this particular range. The narrower the range, the better is your significance, statistical significance. That is how clinical significance is taken place. The next point which you have to consider is the endpoints. Whenever you are doing research, the endpoint which is there is the most important. So you need to have composite endpoint to find out what is the statistical power. The high probability of the disease being present or not present is given by these composite endpoints, and that is your guidance whether we should be utilizing the results of this particular research or not. That is dependent on whether there is high statistical probability that the results which are there are good, or they should not be taken as good. And that is where evidence-based education system comes into picture, because it tells you how to proceed and giving the proper endpoints for that particular patient. Next thing which we have to consider is the validity and bias. Validity is the degree to which the study is likely to be true, believable and free from bias. And bias is whether any other factor is there which is responsible for the result which you are getting. Both of this I will tell you the probability of the disease. And ultimately in evidence-based education system, we don't say anything else but probability of the premium. And there are two different values which are there: positive predictive value, negative predictive value. The proportion of people with positive tests and having the target disorder is a positive. Proportion of people who have negative tests and do not have the disease, those are negative predictive value. Both positive and negative predictive value are very important for us to reach a particular diagnosis and to reach a particular probability ratio. Okay, this is most likely to be this, and that is why when you give your diagnosis, it is done in differential diagnosis also. That brings us to pre-test probability. A pre-test probability is determined by the target result before a diagnosis result is already known, and that helps you in selecting one or more tests. Which test to be utilized? That is on the pre-test probability. Choosing whether to start therapy or not, that is on that. Without further testing or after waiting for the test, that also is to be decided. And whether the test threshold is good or not, that also is given by the pre-test one. For example, what is pre-test probability? For example, there are 100 patients who are coming to a center with pericoronitis, and you find that in all the patients who are pericoronitis, 16% of them have impacted teeth. That means 16 upon 100 or 16% is the chances that a person will have impaction. So the next patient who comes to you in that particular center, and if he has pericoronitis, the chances that he has got the pre-disease probability of an impaction is 16%. So this is how works, and this helps you very much, because then you will go for finding out whether the patient has got impaction or not. Doing the testing and doing it randomly is the difference. In evidence-based, it has to be done on these predictive values. The predicted value tells you that yes, possibility is there, then you go for the test. Periapical abscess, if you want to see, then sinus on the buccal side, pulp chamber is open, negative vitality, all these are in favor of periapical abscess. Whereas periodontal true pockets and vestibular depth and all, these are negative as far as periapical abscess is concerned. And that is why when you want to do the likelihood ratio, each and every test will tell you a higher likelihood ratio. And if you add up all those likelihood ratios, and then if you decide, okay, what is the probability that that particular patient has got a periapical abscess, that is how you decide according to the case summary. What you need to do is put it on this 2x2 table. Whatever results you have done in your research, just put it in the 2x2 table. Formulas are given for everything, and you will be able to calculate yourself, or there are calculators available which can give you the calculation without doing that. Or if you are asking your statistician to do that, he will also be able to do it. But these are very easy things. Do not bother into going into the calculation. Just find out how to put into 2x2 table. For example, suppose if you have a serum ferritin of 60, and you find that 90% of the patient with iron deficiency anemia has that level of serum ferritin, and that 15% of the patient who do not have the iron deficiency anemia also are tested positive, that is your false positive. Knowing this, then 90 upon 15, that is you are 6 times more likely to have iron deficiency anemia if your value is more than 60. This is how probability, likelihood ratio, everything is calculated by telling us, okay, what is the pre-predictive value, and after the test is doing, what is the likelihood ratio. How the likelihood ratio changes before the test is done and after the test is done. That is what evidence base is all about, and that is how it guides you. Okay, do it in the right method. It helps in selection the appropriate test, a likelihood ratio. It is advantageous over sensitivity and specificity because both sensitivity and specificity is depending on the prevalence, whereas likelihood ratio doesn't depend on prevalence. And multiple diagnostics, if you are using the first test which you do, the likelihood ratio which is after the test of the first test can be taken as the first or the pre-likelihood ratio for the second test, and that way your likelihood ratio can be improved on one after another test. So testing should be more in a series base rather than on parallel base. In an iron deficiency anemia, before on the signs and symptoms, you feel that the chances of the person having iron deficiency is 50%. That means the odd ratio is 1:1. So if you calculate, then you find that 1 into 6 is, that means post-test odds are is 6, and post-test probability also is 86%. This is how your probability values increase once you do the test, because you are using the likelihood ratio in a proper manner, and that way your ultimate final diagnosis is more plausible. You can use the nomogram. Fagan's nomogram can be utilized to find the pre-test likelihood ratio post-test and show it. And this is very good for patients, because when decision making is taken, they will be able to appreciate the values much better when you show this kind of graphs. Now let us assume that there are 4 different groups, and that will be the 4 groups which will always be available. Disease positive and test positive, disease negative but the test is positive, that is false positive, disease positive and test negative, that is false negative, and disease negative and false negative, that is true negative. And these are the values for formulas for calculating each of them. So you need to know what are the false positive and false negative, because then you will be able to decide what kind of process we will do, what is the probability. For example, if you have the 2B and you have put your values according to the research which you have done, all these tests which are there can easily be calculated, whether it is sensitive specificity, likelihood ratio positive and negative, predictive values negative, all things can be calculated. Now probability is if it is more than 0.8, then you can confidently say that the patient has the disease. You can start the treatment and test it again just to confirm it. If the probability is less than 0.2, then you know that the patient may not be having the disease. Keep the patient on observation. If any changes take place, then you test. And probable disease at or above, in between these two, at an average of 0.4, then in those particular tests, you cannot treat comfortably, neither can you keep the patient under observation. You have to go ahead and do the testing. And test is most likely for these kind of patients who are in 0 to 0.4 range. That brings us to the cutoff points. Every diagnostic should have a cutoff point, below which the disease is not present, and above which the test is and the diagnosis is positive. This cutoff points are the most important point, and this we need to understand how to develop these cutoff points. For example, let us take a 12 WBC count as a indication that the person has got urinary tract infection. So those persons who are in that particular range of 12 are shown in the Bell's curve in red, and those who do not have is shown in the Bell's curve based on in blue. So these are the two values which you would get when you take 12 as the starting point. Now when you are taking 12 point, you find that in the red curve, 50% of the people are above 12. That means there is a 50% chance there's a test, is the sensitivity of the test which you have done. So WBC count of 12 has got a sensitivity of 50%, and the cutoff point would be 50, because that is a sensitive point. If the patient has got more than 50, more than 12 point, then he has the disease. But at the same time, you will also have to take into consideration that there will be 2% of the people who do not have the UTI but still are showing positive, which is your false positive ratio, which is there, which is 2%. That means you can be sure only in 98% of the patient that the patient does not have the disease. So that is the specificity value. The specificity is very high, but the sensitivity becomes only 50%, and that is how you have to evaluate the value of using that as the means or cutoff point. Similarly, in research also, alternate hypothesis and null hypothesis, both of these can be easily be calculated and seen how effective they are as far as the research is concerned, and you can evaluate what are the kind of false positive and false negative. For example, you have two values like this, and suppose, for example, the alternate hypothesis holds, then the subjects are more likely to have higher value of this variable. So many of the people will have more value of the WBC count. On the other hand, if the null hypothesis holds, then you will have a lesser number of people who are having that point. So if you see that if you take 12 as a higher, then 100% of the people are diagnosed above 6. When you take the cutoff as 6, then 100% of the people above who has the disease will be checked. So this is a type 2 error which is there, the false negative part. And then 94% will be mistaken. So that is your type 1 error. This is the confidence of the test. And the power of the test is depending on how many people are getting positively diagnosed. That tells you the power of the test. So both the power of the test and the confidence in the test are important parameters which tells you whether that cutoff is good enough for you or it is not good enough for you. Because both will have effect on the patient in different manners, and that effect which is there on the patient is what is going to drive your healthcare delivery systems which you are trying to do that. So type 2 and type 1 errors needs to be controlled. Now type 1 error is one where when the test rejects a true null hypothesis. So a type 1 error may be compared with the so-called false positive result, as we have already said. Now if you take a parallel in that Aesop's fable, crying of wolf, that a wolf has come, that tells you that even when the wolf has not come, if you say, that is the false positive, and is called as the size of the test, and it denoted by the Greek letter alpha, and that is the significance of the test, because it tells you the power of the test. And type 1 error is something which you need to take into consideration every time, because even though the disease is not there, we are saying that the disease is present. So type 1 false positive should be as low as possible. Type 2 error is the false negative which is there, and that relates to the extreme skepticism which is there. So even though you have the positive result, you know that the result is negative, you still feel the patient is having the disease, and that is what creates a lot of problem when you have a false negative, because unnecessarily problems are taking place as far as the healthcare delivery. Your decisions for healthcare delivery changes with the amount of type 1 and type 2. So many a times wrong delivery, healthcare delivery, or unnecessary healthcare delivery is possible when you have these kind of thresholds. So suppose if you want to take that fluoride toothpaste, that is your hypothesis that it does protect from against caries. Then when you see the type 2 error occurs when the null hypothesis is false, that is adding fluoride is actually effective against the caries, but the data shows that the null hypothesis cannot be rejected, failing to prove that the diseases means the fluoride is really active against that. In collateral term, this is convicting an innocent person, and in type 2 error, letting the guilty go free. This is how your static evaluation in a clinical case, how it changes. Your statistical testing threshold will always create a certain amount of type 1 and type 2 error, and both these errors are going to affect the way in which the result you are taking. So learn how to do 2 by 2, whether it is for patients or whether it is for research purposes in terms of null hypothesis and the positive hypothesis and alternate hypothesis. Both these things, once you know the 2 by 2 table, you will be able to know how much is type 1 error, what creates type 2 error. It's very clear to you from this particular figure, and it can be done. Now both types of error are problems for individual data analysis. A false positive means unnecessary treatment is given to the patient, and a false negative means the patient has the illusion that I do not have the disease, and then treatment, even if they are available, the patient does not get the treatment which is required, and that is where your healthcare delivery suffers because of the presence of the type 1 and type 2 error, and this is very most important as far as diagnosis is concerned. The other things which you need to know is accuracy, sensitivity and specificity, and their calculation and their meaning, why, where and where, what to be. In all this too, the 2 by 2 consistency table is important. Now prevalence also can be evaluated in the similar manner by the 2 by 2 consistency table, and then prevalence can be calculated from there as shown by the formula. Post-test likelihood or post-test positivity, that is most important. It is the probability that the disease is actually present, and that gives you a really strong value for your differential diagnosis. Test characteristics also can be calculated in terms of all the different parameters, both positive and negative values which are there, and that is how each one of these are very helpful for you in coming to for an individual with a negative test result. Negative value is the probability that disease is actually present, and that is the calculation which you need today. For individual with a negative test, the probability that the disease is really absent is what is done by the negative predictive value. So these two values are important for us to tell you how much probability is there. Probability calculation is the most important. The difference between diagnosis for presence and absence of a disease of abnormality depends on the selection of the cutoff points. As I already told you, cutoff points are important. Changes in the physiological, biological molecule are typically reflected in our diagnostic tests. In contrast, the presence or absence of abnormality or disease is typically dichotomous in nature. And now, this being dichotomous, you need to convert the continuous measure into dichotomous measure. Only then you will be able to do that. For example, you have stage 1, stage 2, stage 3, stage 4 of hypertension. That can be converted, that continuous value can be converted into these kind of cutoffs which are there, and those cutoffs will then be utilized for your evaluation. For example, individuals with a pain-free, unassisted vertical and horizontal mandibular movement, in the kinesiology of mandibular movement in the joint problem, whether the patient has got TM disease or not. So the cutoff between these two generally is taken as 40 mm inter-incisal distance. So if the patient has 39 mm opening, that means he does not have the disease. Whereas the another patient with only 41 mm, a difference of only 2 mm, but he is diagnosed as this. So cutoffs should be important in such a way that it should be realistic in nature. Alternatively, the cutoff points is made 35. The same patient who has got 39 mm is now is disease free now. So that is how you need to say that the cutoffs are the most important part, and for that cutoff points to be evaluated or estimated, you need to have further investigations to be done, and these further investigation will lead you to for a cutoff point for each and every disease, and evidence base promotes that for each and every disease you calculate your own thresholds. If low threshold is selected, when it is important that all individuals who are suspected of the disease are included in that. That means for screening tests, suppose if you are going into the field and doing the screening, you don't want to miss out on any patient who is likely to have a high risk also. So all those patients with high risk will also be included. So you use a lower threshold for those people. Let more false positive tests come. Then you can do confirmatory tests only on those patients. You don't have to do the entire population, and that is how it helps you by taking note. So screening tests should be ultimately utilized in such cases. High threshold is for high specificity, and that means that you want to do it for confirmatory tests. So for life-threatening diseases, you should use that. In contrast, for temporomandibular joint and all, you need not go for such high specific. You can use low specific thing also. So unnecessary, irrelevant and possibly invasive methodologies can be avoided by using the higher threshold of this, and false treatment will be avoided by using the higher threshold cutoff points for your diagnostic test. Now, how to improve the cutoffs? There should be some methodology by which you can improve the cutoff so that you can utilize it in a day-to-day purposes. So use variable cutoffs. So different cutoffs will give you different idea, specific sensitivity in all these parameters which you also. But the most important thing is the ROC curve. So ROC curve is independent of the disease prevalence and other effects, and that is why that particular ROC curve will give you the right cutoff point which is available. Mortality, morbidity of the disease, consequences of overestimate and underestimate, and the cost and time required to perform the diagnosis, all this will be reduced by using ROC curve. So receiver operating characteristics is the methodology for every diagnostic. Unfortunately, this statistics is not very commonly utilized, but should be. Then you can use prevalence for prevalence studies, tolidine test. Prevalence is more important for a test. For example, tolidine test used in a cancer hospital will have a high rate of 51% positivity, but in a general hospital it will have only 6%. So prevalence is important. Pattern recognition is important. As I gave you the example of a duck. So if you have a particular pattern, the chances of that particular cutoff point being proper will be great. Using of series and parallel testing, as I have already mentioned, will increase your likelihood. And things like pulp testing, when you do the pair testing, first you do it on the other teeth. Find out the base level, that is the pre-test probability, and then you go on to the tooth which in which you want to test. That is how pulp testing is done, and that is following the evidence-based pattern of evaluating whether the diagnostic is good enough or bad. So cutoff points and all these factors like prevalence, pattern recognition, series and parallel testing are very important to ultimately decide on whether what is your final diagnosis and what is your differential diagnosis. This is the way decision is taken, and presenting into the paper patient as decision analysis are also important as far as this is concerned. So this is the receiver approaching where you have the false positive rate on the x-axis, and on the y-axis you have the true positive ratio or the sensitivity of that, and then you prepare a graph. The highest point of the graph, if it is closer to 80, is better, and then you can use nomograms also, and nomograms will give you a good depiction of your cutoff points. So this is the way evidence-based practice is there, and evidence-based practice you have to keep it in mind, as Dr. Saket has already explained to us, that you look at the pattern. If there is a maxillary lateral incisor who has got decay, pain on percussion there, it is discolored, pain and swelling, everything is there, your diagnosis of periapical abscess is already made. Then taking a radiograph in such cases, delaying the treatment is not something which you would need or require. So time, cost and discomfort of the test is not warranted at all. It should not be done. Straight away go forward. You can do the radiograph to find out the length of the root or beforehand to find out before what was the case and after the case. That is important. And suppose a patient has come with a pizza burn, you don't have to go ahead and do a biopsy in that. So diagnostic testing needs sensitivity, specificity and prevalence, likelihood and pre and post predicting values, the significance level of the according to the p-value and the clinical significance. A valid cutoff point should be there, and ROC curves and nomogram should be there. Statistics is not Godzilla. Don't be afraid. A diagnostic test calculator is available on the net free of charge, and all these calculations which I have shown you up to now can all be calculated by putting that simply by using the 2x2 table, which I am already telling you is more important. So you have this 2x2 table which you have already prepared, and putting in the numbers which are there, and now you can go on the site of